Hello and welcome to Policy and Systems Change in Southeast Asia. My name is Torres and I serve in the capacity of Executive Director of the Network Towards Unity for Health. The network TUFH advances universal access and equitable healthcare by helping coordinate, share, and build capacity between and within academic institutions, health systems, and communities. By serving as the global connector between these three sectors, we are fostering the creation of new knowledge and collective solutions, building capacity within institutions and systems, and informing regional and global policy. Thank you everyone for joining us on this important topic. If you have comments or questions as you listen to our experts, please submit them in the chat box, or you may participate by turning on your video and unmuting yourself. Please remember that this symposium is being recorded and will serve as a source of information when global thought leaders convene at the Network TUFH's Global Solutions Challenge to collectively design, test, and reach consensus and global recommendations on social accountability, interprofessional education, population health, and community approaches to engage and serve remote and rural migrants and refugees, indigenous, women, and elderly populations. To provide a little context, we understand that around the globe, global health policy leaders and associations such as WHO are convening global leaders, publishing policy papers with recommendations, and releasing calls to actions, initiatives for political leaders and health system institutions to adopt and implement. These global and regional institutions and associations understand that adoption and implementation at the local level is very complex and must take into account the local political and economic circumstances. In one sense, many local groups interpret these global policy and system recommendations as unfunded mandates that don't take into consideration local assets, successes, or initiatives. Additionally, many regional or national change agents may have the will and knowledge to implement these global policy and system recommendations, but either lack the financial support or capacity. In analyzing some of the limits of local change networks and our policy change agents toward local innovation and collective action, we conclude they're stymied by 4 factors. So leaders at local levels must be better prepared to respond to local challenges and optimize their local assets. Their relationships and experiences lead them to focus on local patterns they can observe and control directly. Secondly, local change networks and our policy change agents must take into consideration their own unique barriers that often requires external support networks and pilot funding to demonstrate these practices are efficient and work. Third, local change networks and our policy change agents need to analyze, do somewhat of a policy mapping, the complex dynamics that work in regional, national, and global context to be able to interact with them efficiently to contribute to system change. And fourth, lessons learned in one local context are not always accessible for system-wide analysis and continuous improvement for systematic change or application in other localities. So we conclude that despite agreement with many of the global policy recommendations and efforts by local change agents or networks, many of the current strategies result in limited change. Today, we're going to talk about Southeast Asia's strategies to discuss these solutions and their strategies. So I'd first like to welcome our panelists. We have Pratyush Kumar, who's the chair of WONCA Rural South Asia and WONCA Executive Member at Large. Welcome, Pratyush.
Thank you.
And we have Noel Juban, who's the Professor, Department of Clinical Epidemiology at the College of Medicine, University of the Philippines, Manila, and the Director of the Newborn Screening Reference Center in the National Institutes of Health. Welcome.
Hi to everyone.
So to get us started, I'd like to ask each of you just to introduce yourselves and take 3 to 5 minutes to introduce yourselves, your work, your organizations, as it relates to policy and systems change in Southeast Asia, and then we'll move on to some of the questions. So Pratyush, would you like to start?
Yeah. Hello, everyone. I'm Dr. Pratyush Kumar, and I'm a young family doctor working in rural areas of Bihar, India. And I chair a rural health network of South Asia called as WONCA Rural South Asia, WORSA. And I'm also the executive member of World Organization of Family Doctors. And together we are interested to promote comprehensive primary healthcare, family medicine as the medium to promote primary healthcare, as medium to strengthen medical education and to encourage all young professional healthcare workers to work in a team to achieve universal health coverage. My focus areas are rural health and climate health policy decisions where I work in. Thank you.
Thank you, Pratyush, for that an introduction. Noel?
Okay, I'm Noel. I'm a professor of clinical epidemiology at the University of the Philippines College of Medicine. I lead the social innovation and health initiative in the Philippines, which is funded by the WHO PBR, and we're part of a network. I'm also just got to be involved as the director of the newborn screening program of the country. And I teach epidemiology in the undergrad, and I teach research and do consultative work with some agencies and policymakers.
So we have, looking at, we have India and the Philippines, and I'm not sure how each of one of you sort of work in all the other countries in Southeast Asia, but could you each talk sort of what are the challenges or current priorities, maybe using your own countries as a point of reference, into what are the current policy systems that are being considered or that are being advocated for change? So maybe we could just frame that for us, Pratyush. Like, what are those priorities in India in terms of what people are looking at to change, and what systems and policies are hopefully to be adopted?
India, currently, we are seeing a great amount of change as policy is concerned. There is extreme focus on achieving universal health coverage through something called as Ayushman Bharat program. It means that it has got two components. One is about insurance coverage to all the poor population in India. And the second component is health and wellness clinics. That is to strengthen primary health care. So government wants to open a large number of health and wellness clinics. The earlier primary health centers and sub-centers which were there, they are being converted to health and wellness centers. These health and wellness centers will have some added advantage of screening to all the NCDs, availability of medicines, and options to get the basic surgery done. So it's an attempt to provide a comprehensive health coverage to improve the accessibility of healthcare, which was earlier not there. So this is an attempt which have been started by the government of India. But to understand the overall health context, we need to see the basic problem what's there. That we have moved on to SDGs, but we haven't yet discussed that why we couldn't achieve the MDG despite it's some 4 years after the deadline. We haven't yet achieved the MDGs. So we need to first find out our own loopholes, that where we are going down. That's the problem. SDGs has got its own indicators and it has got its own ambitious goals. But can we achieve those goals? Do we have enough infrastructure? Do we have enough health workers to achieve those goals? These are some prime questions which we need to ask ourselves, our policymakers, that where are the policy gaps? Because SDGs is a global goals. The global goals and indicators that for all countries, it's ambitious, but it does require a great amount of funding to achieve those goals. And with help spending of just around 1.2% of our GDP, can we really achieve those goals? Next is, it's not whenever I say that our country spend just 1.2%, it doesn't mean that only those countries which spend lots of money, they achieve great outcomes. It's not like that. Even with lesser spending, country can have a better outcomes. But in those conditions, we need to have a micromanagement, like a local planning should be there. And so those local planning, micromanagement of healthcare, the health governance should be there. So is those health governance So we need to see that the health governance, because our problem with 1.2 billion population is very huge. From north to south, east to west, the local epidemiology, local health priorities varies enormously. What's needed in north may not be needed in south. We have different disease epidemiology in north and different in south, east and west. So there cannot be any uniform criteria to judge health progress. Even what happened in all those years that we have set global goals to reduce the IMR, MMR. We have got specific criteria. So government accordingly has made a vertical programs to achieve those goals. So somewhere we have also on the line of achieving those goals, we have missed a broader goal of achieving a better health for everyone, health for all. That the we have reduced IMR, we have reduced MMR, but there haven't been much integration at horizontal levels. So we need to work on these policy loopholes, policy gaps, and we need to make a major plan with micro level management, health governance, and we need to look at our health workforce. We need to look at our available health resources, and then we need to make a plan based on the local context and local priorities. So
So,
these are the issues there in India.
So, Pratyush, can I push you a little further and say, so when government or the ministries of health, push certain initiatives, and you said their initiative currently is health and wellness clinics, but you were also saying that they haven't necessarily addressed loopholes. Can you talk about how an institution like such as your institution or a network of institutions converse with or influence government or policymakers to address those issues? How does that happen in India? And then if you have any idea, and how is that similar to other Southeast Asia countries, to your knowledge, from your role as WONCA?
We understood that these problems, like a primary healthcare cannot be delivered by a fourth specialist. Like we cannot have obstetrics gynecologist, a surgeon, a medicine, ENT ophthalmologist sitting, 5 people sitting together at the PSC, because we need to have a generalist approach to solve this problem, provide a comprehensive healthcare. That's why we have pushed to have a generalist recruitment at the primary healthcare level. Earlier, this was not there. At the PSC, at the CSC level, there were 4 posts to have medicine, surgery, gynecologist. But now we have asked to have a recruitment for a generalist, because they can provide a preventive care, promotive, and also they can provide a curative services. Through all our efforts, now the government has there is a new bill which has come out that's called as National Medical Commission Bill, and in that government has promised that we will promote family medicine courses in the post graduation. Earlier, family medicine was not very popular, despite it being designed to promote primary health care. It's not been promoted well. But now the government has realized that to achieve universal health coverage, we did not further fragment our medical education policy into various subspecialties. We need to provide a generalist view so that they can go at the primary care level. They can provide the comprehensive health services which the population demands. So that have been the major achievement. Just like last year, we hosted a World Rural Health Conference, and our Delhi Declaration, which demanded these to have a generalist approach to healthcare services. We have a primary healthcare team led by a family physician, and that's there in the WHO website. WHO has put it on its website, our Delhi Declaration of our last conference. So that's an important achievement which we have done through constant pushing of the government through various channels, either through invitation to conferences or research papers or making consultations with the government agencies. And that's how we work to make them understand that these are the loopholes. And how we have also provided effective solutions which are not very costly to the government. Because if our strategy and solutions are costly to the government, then the government will never. And a general approach to care to provide a comprehensive service is cost effective, is something which is acceptable to the common public, because a generalist makes a long-term association with the families. It has got care, so it has got more acceptability. And in short, I just want to say that over the last 3-4 years, our work has finally led to a new bill which has come out, and the government has been kind to promote a generalist approach to achieve universal health coverage.
Thank you, Pratyush. Let me turn it over to Noel, and maybe Noel, can you give us some context for the Philippines and any other countries in Southeast Asia that you could talk to the context?
Okay. Right now, we have signed at the country level, the Universal Health Act was signed in February 2019. And we're now in the stage wherein the Department of Health is doing its consultations and coming up with the implementing rules and regulations for the bill. And what the UHC means for the various stakeholders is like what they said is that the Filipino patients and communities are health literate, they practice health lifestyle, they live in an environment and to receive an effective care without financial hardship. So this will involve the actors, the healthcare workers, the payers, and the providers and the supplies of the drugs. Right now, what we aim is to come up with a system so that the primary care and the tertiary care and to look into the healthcare system because in this universal healthcare, it is that a large number of the health services will be given for free for all Filipinos, and this will be being paid by the PhilHealth insurance company of the country. They're trying to prioritize and to see which of the programs in the process. I think what is being done so far is to get everybody involved, meaning the DepEd, the Department of Education, and the schools to have a healthy startings for those who are among the children in the age group. There's also some advocacy on participatory action research. And at the end of the day, after implementation, there should be an impact assessment of how this should be done. And we're also receiving, I think, some training grants will be available for people who would do research in terms of the evaluating the implementation of the Universal Health Act of the different programs. So I think they're also advocating researchers to equip them in terms of health technology assessment and impact evaluation so that after a few years of implementation, we can have some outcomes where we can gauge ourselves whether the program is doing its work and which one probably needs to be needs some innovations or something. So everyone are there to the health researchers and the healthcare providers are now working together towards the implementation of the Universal Health Act, Universal Healthcare Bill.
So Noel, a similar question to Pratyush is, can you talk about the interface or the conversation between ministries of health using the Philippines as a framework and change agents? So if like your institution wanted to advocate for a particular system or policy change for government to adopt and then implement, how does that happen? Is it always the government is taking the initiative, or are there examples when groups of physicians or networks of health associations come together and successfully advocate a government to adopt their system or policy recommendations for better health? Do you have any examples of that using maybe the Philippines as an example or other countries?
These policy changes takes a very long time to to come into place, to get implemented, to become a law. As far as South Asian healthcare is concerned, it's very much influenced by the global policies. To be very honest, like WHO policies, it's something the WHO has got very huge influence on our own policies. And so to have to bring something which is uh, important to our own needs, we need to have our uh, our policy agents work in multiple directions, like with WHO, with government-owned policymakers. Government has got its own advisory board. So we need to work with lots of agencies which we feel that they can bring the positive change in the next policy decisions. Like in the past, like the new NMC bill which has come into place now, it has been there with the government for past so many years. Like they really wanted to bring this law, but because of various regions, it was not coming into the place. But with the new government, which is very stable in India, they have the power to bring a new law. Although it's being criticized on various grounds, still there's lots of agitation going on against it. But it has become a law. So to become a law, and what I said that it has promoted family medicine, it has taken a long period of time. We have worked with uh, the agencies like WHOs, and there's even in the Ministry of Health, there's a agency which drafts policy, which work as the technical advisor to Government of India. We have worked with them. We have worked with other advisors which we feel are very influential. So, and the next thing is to put out a research, to start their own journal. We have got our own journal where we publish papers based on our local needs and our local data. Because obviously there is huge data gaps in India and in South Asia. So to make them understand, we need to put out a data that, look, these things, if these things will be there, then it will have a positive impact. And we'll give an example from the West, because all the data which we have, which has shown a positive change, is from the West only. So we take those data, and depending on that, we do up some pilot projects in India. And based on that, we showcase to various agencies, and that's how government listens to us. But it's a very slow process and takes a long time.
Yes, and systems and policy change can be very slow, and but eventually we do get there. So Noel, maybe back to you. Can you expand upon how it happens? Where we take WHO's global recommendations. Oftentimes we can use, as Pratyush said, local research and data. But what's that process again for moving a system or a recommendation into actual implementation or policy adoption?
In our setting here in the country, we have a Philippine National Health Research System, wherein the Department of Health, together with the Philippine Council for Health Research and Development, and the higher educational institutions and the different regional research consortium, works together in terms of addressing issues that are being faced either at the local or at the national level. Means working with the Department of Health for the past 20 years, they have been consulting us at the academe in terms of helping them with program implementation, and also coming up with evaluations in terms of existing programs. I have colleagues in the university that are being consulted or serve as consultants for health policy of the government. So there's a very strong relationship within people. So they have a good working relationship with the different societies when it comes to concerns for particular illnesses that concerns the societies. I think it's a good working relationship with that one. So there's the consultation is there, and they are part in forming in the development of the policy. Like right now, even in the crafting of the implementing rules and regulation of the new bill, there's a lot of consultative work being done with inputs coming from the healthcare providers, from the societies and the academy.
So let me take this a different angle, and and again, to frame it for our participants, and systems and policy change happens. Oftentimes, WHO and other global leaders kind of do this global analysis and say, we have these recommendations on these particular issues. We're all working towards universal healthcare and equitable healthcare. But then it comes down to a local country, whether that be India or the Philippines or any other country in Southeast Asia, who now has to figure out how to adopt these and then potentially implement them. At the same time, you have local groups who are saying there might be some things missing within those global recommendations, and we want to help to do that. So, taking those contexts, then change starts happening. It's very slow. Oftentimes it could take years, but eventually everybody's working toward the best interest of the population. There's this pending question of could we accelerate that system and policy change through external, I guess, outside of the country, resources or capacity? And so I'd love to, Noel and Dr. Pratyush, if you could expand upon what would be the best mechanism for external resources. Could it be consulting, technical assistance, or funding that could accelerate change in a local country? Either one of you want to start with that one?
So there's external resources, as I said, that our own policy is very much influenced by what WHO or leading health organizations, whatever they come out with those policies. So it's very much influenced by that. And the next most important thing which government is looking for is data. And there's huge data gaps in our countries. So we have recently started seeing that in the name of global health, many global organizations have shown interest in low and low middle income countries to do its work. Although there has been lots of debate regarding those countries that those from Europe and America come do research in South Asia. And so it has got its own ethics and the debate part. But what's important is that that we need to have proper data. We need to have proper funding to do some research, because research can only tell that our local data, our local finding, is it similar to what the global data is, or is it something different from what the global findings are? It could be either ways, but only if we do research, we'll come to know that we have got a problem, and is the solution what's the global organizations it's proposing, will it be acceptable to our local population or not? If its application, can our government continue those changes for considerable period of time? Do we have enough resource to implement those changes? So these are some basic questions. Even if those solutions which are being proposed by WHO, it could be very good. But unless we won't do a pilot in our local population, it could be culturally impractical. It would be socially not very perfect idea. It could have many social barriers. The population may not accept it. So we need to do some pilot testing, that whether it's acceptable to the population or not, whether our country, our government can afford these things or not. So the best thing is that to research, that external agencies come here, do the research, involve the local people, involve the local researchers, and then do the research. For impact, and it will have clear findings and won't have much conflict of interest. Thank you.
So, Pratyush, just to summarize from what I understand is, so it's not that these global policy recommendations are incorrect, but there needs to be probably resources, financial resources, to test them out with the local population to see how they'd be acceptable, and then involve the local populations for their adoption. Do those resources have to come external? For example, to India, or are there enough resources internal to India that money just needs to be deployed for those efforts? I guess the question I'm looking at is, it has to be external, or can India really address it itself?
Look, at this point of time, if we just said They just need a funding. You need to channelize the local resources. You don't need to bring local resources from outside. You need to channelize the local resources. You need to invite the local researchers also. And this the funding could be external. Apart from the local resources, the workforce, the research team could be all from the local population, from the local medical colleges, local institutions, local networks. Only funding could be external.
Got it. All right, that helps. So let me, Noel, how would you answer that question?
Yeah, as with India, we look at WHO in terms of policies and directions with regards to health. Meaning, if you said about technical consultants coming in and funding, I think it's something that it's welcome. But there's really a need to test whether these policies will work at our setting, because we are, like for example, you are dealing with 7,000 plus islands wherein you have to make your health services be available to everyone. So it should be, so the local context should also be looked into. It's not, as we all know and we all agree, that things doesn't work the same way and where it is being implemented. And also, I think we should also look at how the local people are innovating in terms of being able to address their health needs. We might have the best solutions, but for several settings, the local might be doing something new that we might be able to learn from. Pilot testing is also one of the things that we do in terms of program implementations, and the learnings from the pilots the pilot test would be a good guide for us to whether to scale up or tweak whatever we need to change in terms of the healthcare programs that we have for the country.
So I'm sort of taking from how this might be applied in Southeast Asia is really that there might be external funding sources that funds a process that brings together the local, whether they be researchers or experts, into the process. And then that may serve as a catalyst towards moving towards adoption and implementation of local policy change. But key to that also is potentially pilot testing. So Noel, how does pilot testing usually get funded so that people can actually test these ideas out that then leads to potentially larger systems change? How does that usually happen within the Philippines as an example, but any other Southeast Asia country?
For the Philippines, I think what we have is a good Department of Science and Technology that is resources to fund pilots. The Ministry of Health also allows us to submit proposals in terms of programs and innovations. So that's one thing that we can tap. And also in terms of other sources, regional sources can be tapped in terms of, there are a lot of agencies but you just have to know what are their agenda, and you have to tailor their agenda with your agenda as well. So I think there are a lot of possible funding agencies. You just have to know which ones will be funding your research ideas or your priorities.
So I'm sharing my screen right now with this idea that it seems to me, from what both of you are saying, that a lot of system and policy change happens when you convene the right people. So this partnership pentagram, which was created back in 2000, really says you have to bring the policymakers, the health professions, the academic institutions, the communities themselves, and health managers to really, this is really framed within social accountability, but it seems to be applicable that saying, unless you have all these groups together, you limit your ability to create and policy and systems change. I thought Pratyush or Noel, if you had any comments on, would you say that's accurate, that unless all these players are at the table, we cannot achieve system and policy change within a country?
Policy change depends in a South Asian countries, and what I've seen, that it depends a lot on political commitments. Like if really committed to bring about the change, if the government at the center is very stable and they feel that these policy changes won't threaten their position, then obviously a policy change comes very quick. But in case of a local government, and if they are not very much committed, it takes very long time for the change to happen. The political commitment and the political stability is very important, and that's what's the main catalyst to bring out the change. If they are there, then it won't take much time. Rest, obviously, the health managers, health professionals, institution, community, they they are the one who will do the all the technical work, will prepare papers, bring out the data, everything they will do. The background work is all done by them, but we need to have a strong political commitment to bring out the change.
Thank you. Noel?
Looking at the partnership pentagram that you are flashing right now, I agree that all of this should be there, but one one must take the lead for this one. It can either be the community with academic institutions, but or the health professionals. But as they said, if there's the policymakers will have to do the will be will play a great role. So a strong advocate coming from any of the five players here would be needed in order to do for a policy to be, I think, crafted and then be turned into a real policy or into a law.
So Noel, you were, and Pratyush, I think you're also saying yes, they're needed, but there also needs to be one that takes the lead. And Pratyush, you said oftentimes it's the governmental policymakers who take the lead on this that are important. It does lead to this question of the institutions themselves. Oftentimes, policy can happen when you don't necessarily, an institution, an academic institution, a health center, or a hospital, can adopt certain policies, even though it has not been put into law for the country itself, but because it's a good practice. And so I wanted to ask each of you to maybe talk about your own institutions and if they've adopted certain policies on, let's say, under social accountability, interprofessional education, because globally, we're saying these are good best practices for people, institutions. It would be great if each country adopted them, but at the end of the day, each institution does not have to wait for government to say this needs to be a policy. Can each of you talk about how we can incentivize, encourage, or maybe through accreditation and certification, individual institutions to act in ways that are globally accepted? So, Pratyush, you want to start again?
Yeah. I'll give example, because in India, each state can have its own health policy. Health is a state subject in India. So each state can form its own health programs. It's free to have its own health policy. So what I have seen when I was in Delhi, that in Delhi they have started something called as Mohalla clinics, which is something very noble, to bring the healthcare closer to the communities. It was to improve the access to healthcare. So those Mohalla clinics was like the population of Delhi, they really liked the idea. They took the services, they utilized the services, and it has really shown that when the health services are much more accessible, they are more utilized, and the outcome is also great. So now many states have started their own mohalla clinics in different names. So that was a very noble idea, and which got very popular, and now many states are following those things. So it's something any state or any institution have started taking an initiative. They've started with some 10-25 mohalla clinics, and they have made some more than 200 mohalla clinics, and now it's being followed by many states. So we need to have a role model from any of the states, any of the institution, and it's something like a pilot project only, and it helps other to know the benefits of doing that. Thank you.
So I think, Pratyush, thank you. That's a great example of oftentimes we may or may not need government to pass a policy, because that can take years. But if institutions take the lead on it, then they may be adopted, and you have this reverse effect. But that was, I think, that was a great example of one way to actually do that. That still takes a lot of time, but can also be effective. Noel, would you? How would you think of institutions taking the lead on adopting global standards such as social accountability, interprofessional education, and then using that as a catalyst for social policy change? So, Noel?
Yeah, I think we have a strong family and community medicine department, and they are the ones who started about this social accountability thing within our university and interprofessional work, and and country have strong association of family citizens for those who did advocacy with regards to that thing. Now, in terms of, I mean, I think we should have a sense wherein we have to recognize the innovations or the results of where people try to improve their own healthcare. I know there were times before that the term best practice is something that we recognize. And we probably at the academe or we at the government should try to look at those other small villages in the hospital or in the academic institution and try to learn from these things. I think there's a lot, we said, other institutions or other government settings can learn from this one. So I think we have to be on the lookout and try to identify them and also recognize them and be it available to other people who wants to learn from this experience or these innovations that they do.
So no, I think that's a good, great point you bring up, that oftentimes innovations and best practices that really work, there is a question of how they get communicated to and then potentially adopted and or communicated and then shared across systems and then for adoption for government or so. And so, yes, there's a lot of innovations and best practices out there, but oftentimes they don't get to the people that potentially could adopt them. And that is almost the sharing platform to do that. So I think it's a great point that that's a great strategy. And maybe the challenge we have within our own communities and countries is how platforms for sharing those innovations and not only sharing them up towards government, but across to our colleagues in other regions or other cities or other countries. So I think it's a great point. Thank you. Let's just do a last round. We're open on any last comments on how systems and policies could be adopted within Southeast Asia. Pratyush, any last comments that you may have?
Yeah, but I just wish there is need to have more research, more innovation, and there's need to focus on local priorities and local context in forming new policies. That's all. Thank you.
Noel?
I think what we should do is share those small successes that we have seen or we are doing in our setting. We should share it either in any format or in any exchange that you can think of, and hopefully we can do the network and some people would learn from our sharing, and also look for support in terms of making them sustainable in terms of their in achieving its target.
Great. Well, thank you both. And I think coming back towards the network, towards Unity for Health, you know, one of the particular reasons we're hosting these systems and policy symposiums, particularly for our regions, in this case, Southeast Asia, is because we also understand that, you know, global policy recommendations are usually correct, but moving them into a local groups for local action is complicated and complex. And we think that maybe the best platform for doing that is, as Noel said, is really creating a platform for sharing these successes across countries that may be as simple as inspiring other people to follow and say, oh, they did it in India, or they did it in Pakistan, or they did it in the Philippines, so we can do it too. So, and then here's a roadmap to do it. And then but I think both of you also bring up this question. It's like, despite our will and our intentions, oftentimes we need some external support that may come in the form of funding for pilots or data and research, as Pratyush you pointed out. Oftentimes you need the data and the research to really drive something. And there needs to be groups that fund a process that really brings together the people within the local regions to say, we collectively can move that forward. So I thank both of you for your time, your expertise, and your knowledge for this. This, again, is recorded and will be served as a repository of information for the future work of TUFH, but also hopefully as an inspiration for others to follow suit and understand how to make it happen within their own particular countries. So thank you both for joining us, and thank you for our participants.
Okay, thank you.
Thank you.